Assalamu alaikum. Good morning. This is my first time in Kuwait, and it's a pleasure and I'm honored to be here to share our first year experience of PET MRI, looking at the clinical role of PET MRI and challenges we have faced during our first year. 2012 was a very eventful year for us in UK. We celebrated Queen's Diamond Jubilee. After that, we had Olympics, which was quite fascinating. And then it came to PET MRI commissioning, which was a very tedious task. This is basically a Macmillan Center where we spent about a couple of millions to install this new cancer research center. And towards the basement, this was the installation of the PET MRI. You have basically gone in detail in the previous lecture about the APD. So this is our 3T PET MRI based in the basement of the Macmillan Center. This has got the inner core of PET and outside is the MRI. So this reflects the inner core of the MRI capsule. There are different modalities available by different vendors. Philip have got a sequential where the patient goes in, goes through the MR, and goes into the PET scanner. There is a temporal delay between the scanning. So everybody claims who are using the Philips that there isn't any misregistration, and there are softwares available to correct those differences. We have got this simultaneous where the acquisition is taken side by side along with the acquisition of PET and along with MRI. This is a very nice depiction of what everybody is expecting of MRI. Everybody is anxiously waiting what will be the outcome. I think it is a multi-modality approach to PET MRI. To my personal experience, I've been using it for 1 year. It is a great toy to play with, and it has got great potentials in good hands. Sitting back by the clinicians, thinking about it, saying that what would be the benefit when we can reap everything out from the MR, but there is an advantage, but it has to be directed through the multidisciplinary approach where there are difficult cases. So we are still waiting. I think we need a joint team effort in order to progress and establish our services for the clinicians. The clinicians are our main target. So we need to have approvals from their referrals adequate, which justifies. So I think that is the way forward. This just highlights the advantages and disadvantages between the PET, CT, and MR. We are very familiar with the CT and MR and PET, but we haven't got the enough experience between the PET and MR. There are limitations where I'm going to talk about it, but I think the previous speaker nicely depicted the whole experience. We know that MR has got high signal to noise ratio, characterizes metabolic and functional parameters nicely, has got poor spatial resolution, but joined with CT, it has got improves the resolution significantly. At the expense of very high radiation exposure and CT component with the PET, I still advocate that it is the best modality available for lung and mediastinum. There are literatures available which says and validates that PET-CT is the modality of choice for staging lung cancers and mediastinal lesions. On the other hand, MR is no doubt reduces the radiation from MR, but looking at the newer CT modalities which are coming out, 128, which with higher soft tissue and more advanced soft tissue correction, we are thinking of reducing the dose by 2 to 5 millisieverts. This is our local protocol we follow. We do a total body and we do 5 bed position. We acquire the acquisition MRAC, and alongside with that, each bed position is between 4 to 5 minutes. Alongside that, we take DWIs and T2 haste axially, and side by side axial coronal wipe 2-point Dixon. The whole time which is required for this is about 5 times 5, about 25 minutes max. And if we want to do any specialized targeted imaging, so add another 30 to 45 minutes. This has already been discussed. We use 2-point Dixon method. We use in-phase, water, and fat. You add and subtract, you get the central mu map. It is very important that we look at the mu map first, whether there is any artifacts which we need to encounter and take into consideration when we are reporting. My apologies, this is not working. This was our acquisition of the whole body. So we'll go to the next slide. These are the tracers we are at present using. So we have got FDG, integrin, gallium-68, FLT, F-MISO, this is research. Integrin and F-MISO are the research, and choline. We do quite a lot of choline for prostates, brain, for pediatrics, and gallium dotatate for ludotherapy assessment, and some of the patients we do triple regime with MIBG, gallium, and PET to assess treatment. The comparison is just basically between the angiogenesis, we use integrin for PET and MRI for DCE. For hypoxia, we're using F-MISO and BOLD for MRI, and membrane turnover, we're using choline and MRS for MRI. Some challenges and limitations. I think since there are limited availability because of the resources, there are, I think to my recent knowledge, is 7 in the world and only 1 scanner in UK. We have already talked about the attenuation correction. We have got quite a lot of problems, especially we do quite a lot of neuroimaging. The PET quantification does not relate to what we get from MRI. So we are still working on it, and we use 2-point Dixon method, and the attenuation we get, if there is any artifacts, it is quite horrendous. So I think attenuation is still a work ahead for us to resolve all these problems. Proof, I think for clinical benefits, people have been using side-by-side reporting of PET, CT along with MR. I think there are some drawbacks with that, but with the benefit of simultaneous, the temporal shift is being resolved, and movement artifacts are less and less. However, the long MRI examination is one of the problematic area because patients, these are very, very selective patients, and the patient cannot lie for very long on the table, and patient comfort comes as a priority for our services. And we have to target the protocols which are shorter, quicker, and which can be easily readable for the radiologists or the physicians to give an interpretation of their results. I still wonder how fast and quickly can we integrate the PET MRI into clinical workflow, because the time constraints are on our other side, because it does not comply with the, in concordance with the PET CT, which is very, very quick. We do about 26 PET CTs in a day, whereas hardly we are managing, just struggling to go with 8 patients at the max at present. Again, we talked about earlier about the patient pool, who is going to refer, and how are we going to get the patient, and how are we going to select the patients is still a task ahead for us. Training of technical and medical staff, we have been fortunate because it's one of the centers in UK where we have got dual qualified physicians. We have got radiologists and nuclear physicians. I'm duly qualified, so we can report as a single reporter and authorizes our report. We don't need any dual reporting. Cost and time efficiency is one of the major factors. I think now we are charging about £1,600 for a scan. And like other European countries and US, we are not privatized. We are NHS, so everything comes from the state, so that doesn't bother us. We can always charge them. Coming now back to the indications, I think the principal indications would be the neurology. I'm not going to touch on any I've taken out from my slides. I'm not going to go into any details of the neurology or pediatric aspects of these imaging. So I think neurology is one of the major, where we are looking into the gliomas in pediatric patients, dementia. We're looking at epilepsy in young patients, targeting and directing the surgeons for the focus of epileptogenic so that they can plan surgery. This is one of my patients. Pediatric is one of the major groups which is going to excel, is the brain tumors. This is a child who had brain surgery and they were worried about local residual disease, and MR was inconclusive because of post-operative changes, and they cannot make sure that whether this is inflammatory or this is residual disease. However, the CHOLINE PET nicely depicts the focus of uptake there, and if you see there are spinal drop mets. Sorry. The other is the major bit is the oncology. I think this is the major from the oncology side. Other than the lung, we should be able to scan the patient below the diaphragm and above the neck. Cardiology has been nicely dealt with, so I don't have to go into detail. And the major component of PET-MR at present is the research. PET-MRI provides one-stop shop. It increases the diagnostic accuracy, and cost implications remains to be the challenging factor. And the major aspect would be the research, because 40% to 50% is the research time allocated to our scanner. By utilizing the PET-MR service, integration can improve the diagnostic workflow. By combining the bits of the MR, like the function and the tracer kinetics, which we are still struggling, we should be able to provide a very comprehensive and directed reports. Combination of the DCE, DWI, and the tracer kinetics used for PET would be a further informative data that would provide better diagnosis and target the clinicians to appropriate treatment. Staging with less radiation exposure. We are in a bit of publishing our data because people have advocated, the Munich group, Tübingen group, they advocate that there is no much difference between the T&M staging. Our paper shows the clinical impact of PET-MRI, which improves this clinical significance by 5% in accurately T staging of the disease. There is no difference between the M and N staging compared to PET-CT. They are in par. But the T staging, there is significant improvement and changes the management plan for the patient. So we can direct this management according to the findings. The other aspect, by using the DWI and the PET functional activity, we should be able to predict response evaluation and response failure. The other paper, which is in line and soon it will be published, it looks at the SUVs and DWIs in patients having prior to treatment and post-treatment, and to see whether we can predict response. No doubt the MR provides better tissue contrast. That's why you improve the tissue resolution, and you can accurately stage the tumor in comparison to CT. CT, however, remains the modality of choice for lung and mediastinum. I don't think so. There are still people, even in our department, we are still trying to convince people that MR is the modality and is going to replace the CT. I don't think so. Because the MR can only visualize to a certain level, beyond certain level. Below that, the resolution fails. And if there is a small tumor or a metastasis, you are going to miss it. Now, I'll show you some interesting cases which I think would be beneficial. It's 70 years old female with history of colorectal cancer, resected, hysterectomy a few years ago, and it was directed by the MDT. What is the pelvic mass? You see the good resolution of, if I can, so that's the tumor there. They thought there is extension into the posterior wall of the bladder, and probably they thought this is a patient of colorectal cancer. The CEA was borderline. They weren't sure the primary was from the colon, sigmoid colon, and extending into the vagina and going into the, so this was, I was in the MDT. So I tried to convince them the epicenter is in the vaginal wall. The patient had a hysterectomy. I wasn't told what the hysterectomy was. It was a couple of years ago. And if you look at it, the inguinal region, there is a node there. So the drainage pattern follows from the vagina into the inguinal region. If there was something from the sigmoid, there should be some nodal disease here, which wasn't. So I had asked them to go in and do a biopsy and get a diagnosis. If you see here, that's the vaginal wall. It's all thickened, and this is the desmoplastic reaction, probably from previous surgery, and tumor recurrence. Probably tumor is extending from here, going there and there, causing a desmoplastic reaction. So this is, this is very interesting. The same patient, because of the desmoplastic, the tumor which is epicenter, look at this. This is high signal there, and activity there. These are the ureters. So there's the other importance. One-stop shop, you have identified the tumor, you have staged the disease. Now you're telling the clinician there is something wrong, and this is Friday night. So you have to look into this kidney because it's not functioning. So we went up and scanned the kidney. So look at the difference. This is excreting and this is not excreting. So they had to go and stent this before it fails. This is a child we did a choline, had a pineal tumor, and this was response to treatment. That was staging, now this is response to treatment. That's the tumor, sorry. So that's the tumor there. Look at the size, this is post-treatment. It's very sensitive, sorry. These are the axials, so tumor there is gone, there, and look at the functionality there. So it's significantly reduced. These are the fused images. Nice images. The other aspect is the brain dementia. So we can nicely say whether there is dementia or not. Look at the activity. There is reduction in the parietal, biparietal, and temporal region. This was the parietal-temporal. And this was Minoshima. It gives the quantitative representation of the uptake. So if I can bring the cursor. So look at this. So high signal signifies. So confirming that this is dementia of that area. So this is the epilepsy we talked about. So trying to localize the focus. So that's the focus area, confirming the site. So this can get the targeted treatment, and they can go and operate on this. And tectography directs the nerve pathway, so the surgeons can avoid and reduce the morbidity post-surgery. This is a post-operative case. This is very interesting. Again, MDT referral, discussion whether there is sepsis. This is cervical cancer, where a patient had so many surgeries, radiotherapy, so they were not sure what's happening. There are changes on MR, which could be inflammatory, could be recurrence, and the extent of the disease, they were not sure. So we've got diffusion and ADC, so that basically that area with the arrow shows the low signal. So it confirms there is something going on. So if we look at the fused images, it shows the activity, it shows the extent, and it shows the involvement of the nerves, which is extending into the sciatic and coming out into the thigh. And if you see, again, there is causing obstruction of the left ureter. So this is again coronal sections of the same patient. The other major bulk of our patients are choline, prostate. These basically encounter about 40% of the normal pathway where they are unsure of their recurrence residual disease post-treatment, because MR is very good in identifying a tumor. So these are 40% of patients which are referred to us where PSA is rising, we are not sure where is the disease. So this is a post-radiotherapy patient. If you look at on the left side, this is, you can't see anything. These are the peripheral zones where you normally see the tumor. There's no low signal, but if you look at the fused image, there is a tumor sitting there which is causing the problem. This is a patient. So this is a patient with osteosarcoma of left mandible. So the top row shows the pre-treatment and the bottom row shows the post-treatment. And the first on the left is the MR, and the second is the AD diffusion, DWI, and then the fused coronal and axial. So if you see the tumor size on MR, you cannot say whether there has been a response to treatment. Even on the DWI, which is very sensitive, but it does show some reduction in the diffusion, but there is some activity. But on the other hand, if you look at the extreme right side, there is no activity. So there is very, very good response, and even though there is no size. So size is not the criteria of measuring response, but according to research, their size is one of the factors. Gallium is another major bulk of our referrals. We do triple assessment for neuroendocrine tumors, neuroblastomas. We do MIBG, we do PET-CT, and we do gallium dotatate. And then we decide in a multidisciplinary team whether this patient needs MIBG treatment or ludo treatment. So this is a patient with recurrence in the metastasis to liver, had surgery and RFAs to the liver lesions. I don't want to touch it, disappear. So basically these are cysts. Some of them are changes post-surgical, and then there is focus of activity with rim enhancement here, which was missed on MRI. Lung cancer. So it's a large cancer there. So if it's a large lesion, no doubt if you see a plain X-ray, you should be able to pick that up. But it nicely shows the T1 fused images. ADC corresponds to the high signal. So high signal in DWI, low signal suggests malignancy. We talked about artifacts, and I talked about the mu map. So mu map is very important on the left. If you see, there is misregistration, and we looked at it. We were not sure why this has happened. So we rang around, we talked about to the clinicians. As usual, the clinician, they do not give you history. So we looked at the MR sequences, and we were able to pick it up that this patient had had repeated transfusions, and there were iron deposits within the liver, which was causing this artifact. So one should be aware. And if you look at in the middle and the right side, the attenuation correction map shows defects there. But on the next one, you see the non-AC does not show any defects because it does not overcorrect. And if you see in the center image, you just barely see the dome of the here, low signal there, and here, which is causing problem. In conclusion, I think PET-MR is quite promising. Especially, there is a great potential for research and great impact on the clinical applications. Once it's tailored according to these organ-specific protocols, and should be introduced to reduce the scanning time and to improve patient compliance. I think there is clinical routine application. It will be one-stop, mainly in the pediatric, neurology, prostate, liver, and the list goes on. And integration of this probably give us better diagnostic accuracy, anatomical definition. However, the quantitative and qualitative remains the same as PET-CT, looking at the SUVs and the images in the chest and mediastinum. Research applications alongside with the functional and the molecular and metabolic imaging side by side, we can predict the therapy planning, response to treatment, and some biological phenotyping of the disease. Training is mandatory because most of the centers, they have got two side-by-side physicians reporting. So specialized training centers should be advocated to these technologists and the medical staff to expedite their learning curve and to produce good reports. In the end, I just want to conclude with this, that radiologists and nuclear physicians are being bombarded from all over. The imaging scenario is becoming more and more advanced, more complicated, more and more pressure. So we get phone calls from all the physicians looking at imaging report, Friday night, you need to report your normal, you're confused, you don't know, you look into the treatment plan, looking into because they are not referred, and surgeons are calling you, they've got a patient, they need to know the report. All this complicates the whole scenario, MDT, reporting time, reimbursement, documentation, complex imaging, and looking at the so wide spectrum of images. And I think the PET-MR is the solution. Thank you.